If you've got a positive variant for MTHFR, or you're curious about this topic, and maybe you've run some labs and you're now staring at a list of methylation supplements with no framework on how to actually begin. The problem is not access to information about this topic. There is plenty of that out there, but the problem is most of it skips the steps that determines whether any of it is going to work for you. What your system is expressing right now is one of the most important pieces of the methylation conversation, not just what your genes say on paper. I'm Dr. Kenny, root cause health detective and IFM certified functional medicine practitioner, and we're going to close that gap between the information and how it's actually useful for you. Here's what gets missed most commonly in these conversations. Most MTHFR content talking about methylation treats a positive result on a genetic test like a diagnosis. You have the variant, so therefore you need the supplement. But that is not how this gene or methylation works. Think of it as a dimmer switch, not a light switch. The variant doesn't just flip methylation on or off throughout your body. It turns the dial down or up, but how far it does so depends entirely on what else is in the room. Think about things like cofactors. These are the supporting nutrients that the enzyme needs to run smoothly. Other factors include your overall nutrient status or the environmental load that your system is carrying. The gene sets a tendency and a potential. Your current functional status is what determines how much of that tendency is actually showing up in your body right now. And that's how genetics work in practice. They are not fate, but they provide context. The black and white discussions of genetics have largely evolved since the 90s. And one other nuance-based factor that is so important and turns on light bulbs for many of my patients is understanding that MTHFR has gained the most popularity in this conversation, but it is only one of many genes that affect methylation across your genetic potential. And these are the distinctions that determine everything about what supplement you should start with, in what dose and in what order, or whether or not you need methylated supplements at all. And you cannot read that from the gene information alone. So before we talk about what methylation supplements are appropriate for your situation, and we will get to that, I want to establish what you actually need to assess first. The question I get all the time in some version or other is, should I start with methylfolate or methylcobalamin? And my answer is almost always, before either, we need to know what your current methylation status actually is, because the gene variant is probabilistic. It tells you that the MTHFR enzyme may be running at a reduced efficiency, but it does not tell you how much, and it does not tell you whether your system has compensated, and it says nothing about the cofactors that determine how efficiently that enzyme functions in the first place. Perhaps the most underrepresented piece of this conversation, the one that almost never shows up on MTHFR content, is riboflavin. That's vitamin B2. We hear B6, B9, B12 all the time, but riboflavin is a cofactor for the MTHFR enzyme itself. Think of enzymes broadly as these protein-based chemical structures in our bodies that oversee chemical reactions running smoothly. And they require these cofactors or nutrients to fit into specific physical slots that allow that process to run smoothly. And research from a randomized control trial out of Ulster University found that riboflavin supplementation meaningfully altered the way that DNA methylation took place. This is essentially the way your genes are turned on or off. And this happened in adults with the homozygous TT genotype of this MTHFR enzyme. That was alphabet soup, but homozygous TT just means that the person inherited the gene variant from both parents, which is associated with the most significant reduction in methylation activity. What this means for you is that the gene variant that you're trying to potentially work around may actually respond better to a B2 supplement that you're probably not taking compared to the methylated B9 and B12 that everyone is recommending. If you want to better understand this relationship and how to assess this, I've put together a free research summary that's in the pinned comment and the description below. So check that out. It includes some of the practical takeaways as well as the research citations that I used for this particular video. Let's illustrate this idea with a concept that I call the expression gap when it comes to genetics. And this is that distance between what it shows on paper, like your MTHFR status, and how that process is actually playing out in your chemistry, such as how your methylation pathways are actually expressing themselves. Two people can have the exact same types or genetic variants present, and one of them can be producing homocysteine in the normal range while another is significantly elevated. If you've come to this conversation around MTHFR and methylation, you've likely come across the word homocysteine, and this is a compound that the body produces as a byproduct of methylation. When it builds up in the body, it's a signal that the pathway is backed up, and this has implications in pro-inflammatory states in the body. So the same gene may have a completely different expression depending on the individual. The difference is not the gene variant being present or not. The difference is how it is operating in the environment of the individual. Research that was looking at women with MTHFR variants found that homocysteine levels were directly tied to B12 and folate status, not the genotype alone. As B12 status improved, homocysteine came down in women that were carrying the variant on average. In women without the variant, B12 changes barely moved the needle. What this means is that homocysteine is reading how your system is actually functioning, not just what your genotype is. And that distinction is the one that changes your next step when it comes to supplementation or not. So what does this mean practically, step by step? It means that the form debate about which form of folate you should take, for instance, is the wrong first question. Whether it's 5-MTHF or folinic acid or methylcobalamin or hydroxycobalamin, those decisions come after you know what your functional markers are actually showing. Homocysteine is one of those markers. Methylmalonic acid, abbreviated MMA, is another. It's a functional indicator of B12 status as well at the cellular level, and it's distinct from something more commonly run like a blood serum B12 test. In fact, this conventional marker can look normal while your cellular function is still silently impaired underneath. And homocysteine in the plasma is not just a heart health marker. It's a readout of where methylation pathways are backed up and by how much. This is where the supplementation conversation often goes sideways. When someone gets an MTHFR result and starts with the methylfolate or the methylcobalamin, they're adding input to a pathway without first understanding the pathway's current state, if that makes sense. If cofactors are depleted, like B2 or B6, if magnesium is inadequate, adding methyl donors can accelerate an already stressed out methylation system rather than support it. It's just not that black and white. This isn't a reaction to the supplement itself, which is really important to note. It is a systems-based response to a mismatch between what's being added and what's actually being used before the body can handle it. And we could get really dense on this topic, but I'm going to try and boil it down to the basics for you. Methylation is not some standalone, isolated process in our bodies. It sits within a larger network. The transsulfuration pathway, this is your body's alternate route for clearing homocysteine, if you will, by converting it into an antioxidant known as glutathione. This runs parallel to methylation, and it depends on B6. Riboflavin, B2, as we covered earlier, governs this MTHFR enzyme activity directly. Magnesium bathes and supports both of these processes as well. And essentially, when we talk about methylation, we're looking at these little tags called methyl groups. They activate the processes like DNA expression we talked about earlier throughout the body. You can think of this methylation capacity conversation as a hub of a wheel with spokes. Methylation sits right at the center, and the spokes themselves, B2, B6, magnesium, even the transsulfuration connection or branch, these all determine whether or not the center can function at capacity. If one of the spokes is damaged or underperforming, it doesn't run as smoothly. In fact, it wobbles. And research confirms this dependency on the cofactors or the spokes of the wheel. In fact, a Tufts University study was looking at cells that contained the same homozygous TT variant or two copies of the less efficient gene variant. And they compared it to normal controls, those that did not have any of the MTHFR variants. And it looked under adequate nutrient status, meaning the colors were present, and it did not find a functional difference in homocysteine accumulation, meaning the roadblocks were not occurring as long as there was adequate cofactors present. The functional impairment itself only emerged when both folate and riboflavin were simultaneously not present in high enough amounts. And it's important to note that this was just a cell culture study, a lower form of evidence compared to a human clinical trial. But it shows a possible and likely mechanism, not a clinical outcome here. But the mechanism matters. It tells us that the variance impact is conditioned based on the nutrients that that enzyme is bathed in. Are they present in high enough amounts or not? And it's less dependent on the gene itself. The implications for this are worth understanding because the TT homozygous genotype is often described as having about a 50 to 70% reduction in enzyme activity when it comes to methylation. That's pretty noteworthy. But if your cofactor status is high enough, that reduced activity may not be expressing as a functional problem. And if the cofactor status is depleted, the problem isn't primarily the gene, it's the nutrient piece. So here's where you should start before supplementation. Figure out your homocysteine levels, and not just serum B12 or folate, which can look fine while your functional status is impaired, like I said. Also, methylmalonic acid. It reads your B12 activity at the cellular level, which is distinct from the standard blood tests. These two labs alone are a great starting point, and they're pretty easy to tack on to even a conventional workup. And once you have those, there is a broader window worth opening. An organic acids test, or OAT, is a urine-based test that maps out how efficiently your chemical pathways are running throughout the body, but especially at the mitochondrial level. And this includes your functional B vitamin utilization and specific processes that could be backed up. And for riboflavin specifically, which is a nutrient that isn't commonly tested in the functional or the conventional space, an assessment of your functional B2 status matters, particularly if you're one who has the homozygous TT variant and are wondering whether or not methylated supplements are actually working for you. And I'm curious, if you had a positive MTHFR variant test, no matter where you are in the spectrum, and you started supplementing, what did your practitioner assess before recommending a supplement, if anything? Did anyone check homocysteine, methylmalonic acid, or your functional B2 status? Drop it in the comments below. I read every one of them, and it might help people who are following along wondering some of the same thing. So the honest nuance that you should be taking away from this conversation is that not every person with an MTHFR variant needs a methylation supplement right now. Some do. Some need to address cofactor depletion first and then reassess. Some need to look at why homocysteine is elevated in the first place. Is it a methylation issue? Is it a transsulfuration issue? Or a B6 deficiency driving this clearance issue through a different route altogether? These are not the same problem, and they don't have the same solution. The sophistication in this space has been captured by many debates as well. Methylcobalamin versus cyanocobalamin, 5-MTHF versus folinic acid, the proprietary forms versus the patent arguments. That layer of complexity and confusion is real, but it is still downstream of a more foundational assessment that most people haven't done yet. And the form debate is almost irrelevant if the cofactor piece has not been put into place first. So let's talk sequence. From a systems-based perspective, the methylation investigation has a sequence. We talked about the functional markers first, homocysteine, MMA, and maybe even an organic acids test to get a better snapshot of the cofactors involved. Then the methylation support itself can come in, sequenced based on what your functional markers actually indicate. That sequence is what closes the expression gap, not just picking a methylation supplement alone right off the bat. So if you're working through a pattern that hasn't fully resolved, even with targeted methylated supplementation, that's often the place where the question got skipped altogether. And that's where a more complete investigation tends to change things for most of my patients. If that kind of structured case review is something that you're looking for, and you're in one of the states that I practice in, the next step is to check out the short training that I have below that prepares you for a health mystery map call application. There's a companion video that matters just as much as this conversation, and it answers the question, what happens when someone starts a methylation supplement and reacts? It goes a lot more into the 6, 9, and 12, as well as the cofactors, as well as common symptoms that come along with overmethylation, like racing heart or sleep disturbances and anxiety. That video is linked to right here, and if that's something that interests you, check it out. I'm Dr. Kenny, Root Cause Health Detective. Thank you for watching, and I will see you in the next video.